So, good afternoon my students, hope you are keeping well at your home. So, this is a new experience to you, the e-classes. Now, today I am going to discuss the diaphragm. Now, there are different diaphragms in our body, you know by now, the pelvic diaphragm, the diaphragm oris, the diaphragm ocelli. But the diaphragm I am going to discuss today is the thoraco-abdominal diaphragm or the diaphragm. Now, as you know, what is the diaphragm or the thoraco-abdominal diaphragm? It is a musculo-aponeurotic partition between the thorax and the abdomen, and it normally forms the roof of the abdominal cavity, lying over the liver, Now, as you know that it forms the roof of the abdomen, and it also at the same time forms the floor of the thoracic outlet. You know the thoracic inlet is an open space through which certain structures will enter, but the thoracic outlet is almost closed except a few structures which will go through the diaphragm through its openings, which I will discuss later on. Now, the diaphragm has got two cupola. So, what do you mean by cupola of the diaphragm? These are as you know that towards the thorax, the diaphragm is convex. Towards the thorax, the diaphragm is convex, and the highest convexities of the diaphragm are what are known as the cupola. There is one right cupola and the left cupola. Obviously, as the right lobe of the liver is larger when compared to the left lobe, the right cupola or the right dome of the diaphragm will be at a higher level when compared to its left dome or the left cupola. But the domes or cupola are not the same. The domes are the convexities, whereas the cupola are known as are referred to as the highest point of those convexities. Now, the total surface area of the diaphragm is 270 square centimeters. It is 270 square centimeters, and the average range of movement of the diaphragm during quiet respiration is about 1.5 centimeters. And it exerts a piston-like action to the thoracic cage, and thereby increases the vertical diameter, mainly the vertical diameter of the thoracic cage during respiration, and that is why it is also known as the chief muscle of respiration. Now, to tell about the origin of the diaphragm. Now, the origin of the diaphragm, as you know, it spreads like an umbrella. At the thoracic outlet, which is apparently closed, and it owes its origin to three areas. Number one, the sternal origin. The sternum has already been taught to you. Still, I will recapitulate. It takes origin from the posterior surface of the xiphisternum by two fleshy slips. This is about the sternal origin of the diaphragm. So, number one, the sternal origin. Number two, the costal origin. The costal origin, the diaphragm takes its origin from the lower 6 ribs, inner surface of the lower 6 ribs, along with the not only the ribs but also the corresponding costal cartilages, and this origin takes place by interdigitating with the origin of the transversus abdominis muscle. Now, this is about the costal origin. So, two origins we have already learnt. Now, the third origin, that is the vertebral origin. Now, this vertebral origin has again got three parts. First of all, the two crura of the diaphragm, or what you know as the crus of the diaphragm or the crura of the diaphragm. There is a right crus and the left crus, and you know that the right crus is larger than the left crus. You can see here this is a schematic representation of the diaphragm when you are seeing it from the abdominal cavity, So this is the anterior aspect. You can see here the xiphisternum. This is the posterior aspect. Here you can see the two crus. This is the right crus and this one is your left crus. And you can already see here in the diagram that is the right crus is larger or more fleshy when compared to the left crus. Why it is so? The reason is obvious, because the right lobe of the liver is much larger than the left lobe. So to depress or to exert its piston-like action on the more massive right crus of the diaphragm, the right lobe of the liver, the right crus has to be more fleshy to exert more force. Now what about the origin of the crus of the diaphragm? The right crus takes origin from the bodies of the first, second and third lumbar vertebra. Right crus takes its origin from the bodies of first, second and third lumbar vertebra. And the left crus takes origin from the bodies of the first and second lumbar vertebra. So the left crus takes origin from the body of first and second lumbar vertebra. And on the midline, they are connected by means of a ligament which is known as median arcuate ligament. So the two crura are connected in the midline, forming the median arcuate ligament. And this median arcuate ligament lies in front of the body of the 12th thoracic vertebra, and it also forms the anterior boundary of the aortic opening of diaphragm. Now these openings of the diaphragm I will discuss later. So this is about the origin of the crus. Now the right crus, the fibers of the right crus, you can see here, the fibers of the right crus go further into the substance of the diaphragm and split to enclose the esophageal opening of the diaphragm, which is situated in the muscular part of the diaphragm. So a few fibers of the right crus travels into the substance of the diaphragm, muscular part of the diaphragm, and splits to enclose the esophageal opening of the diaphragm. And the right crus close to the esophageal opening also gives attachment to the suspensory muscle of the duodenum, or the ligament of Treats, which we have already been taught when I was discussing the gastrointestinal part. The ligament of Treats, which will connect this part of the diaphragm, the right crus of the diaphragm, close to the esophageal opening with the duodenojejunal flexure, and it helps to keep the duodenojejunal flexure in its position. And this ligament of Treats is a remnant of, to recapitulate, you know it, is a remnant of the superior retention band of the primitive loop of the gastrointestinal tract. So this ligament of Treats is a remnant of the superior retention band of the primitive loop of the midgut of the GI tract. So this is about the right crus. Now, other than the body of the lumbar vertebra, the vertebral origins of the diaphragm has got other two parts. They also take origin on either side. On either side, you can see here, on the right side and also on the left side, from the medial arcuate ligament. Medial arcuate ligament. Medial arcuate ligament. And the muscle going below the medial arcuate ligament or posterior to this medial arcuate ligament is the psoas major. Is the psoas major. And this medial arcuate ligament is said to be a condensation of the fascia covering psoas major, or you can say the psoas fascia. The psoas fascia. This medial arcuate ligament runs from the body of the first or second lumbar vertebra. Medially, the medial arcuate ligament. Mind it, medial, not median. Median arcuate ligament is the ligament which connects in midline the two crura of the diaphragm. It is something different. It is the medial arcuate ligament. It is derived from condensation of the psoas fascia and runs on each side from the bodies of the first or second lumbar vertebra up to the tip of the transverse process of first lumbar vertebra. So it runs from the sides of the bodies of first or second lumbar vertebra up to laterally it extends up to the tip of the transverse process of first lumbar vertebra. So this is all about the pair of medial arcuate ligaments. Now the third part of the vertebral origin of diaphragm, is the lateral arcuate ligament. It is also paired. You can see here the lateral arcuate ligament on the right side and the lateral arcuate ligament on the left side. The muscle going under this lateral arcuate ligament has been marked here. This is the quadratus lumborum. Quadratus lumborum. And the lateral arcuate ligament is derived from the condensation of the anterior layer of thoracolumbar fascia. So the lateral arcuate ligament on each side, it is derived from the condensation of the anterior layer of the thoracolumbar fascia. Now on each side, the lateral arcuate ligament runs from the tip of the transverse process of L1 vertebra of the first lumbar vertebra medially and laterally up to the lower margin of the 12th rib. You can see here the 12th rib. These are the two 12th ribs. So the lateral arcuate ligament medially is connected on each side to the tip of the first transverse process of first lumbar vertebra, and it runs to the lower margin of the 12th rib, and is derived from the condensation of the anterior layer of thoracolumbar fascia. So these are the three components of the vertebral origin of the diaphragm. So to summarize the origin of the diaphragm, it has got mainly three types of origins: the sternal origin from the xiphisternum, the costal origins from the lower 6 ribs. You can see here 12th, 11th, 10th, 9th, 8th and 7th ribs. So the lower 6 ribs along with their costal cartilages, and these origins interdigitate with the origins of the transversus abdominis muscle also. And last but not the least, perhaps the most important, is the vertebral origin. The vertebral origin can again be divided into origin from the lumbar vertebra, origin from the medial, a pair of medial arcuate ligaments, origin from a pair of lateral arcuate ligaments. This is all about the origin of the diaphragm. Now, one thing you may be asked in the examination, that is, the origin from the sternum. The sternal fibers of origin of the diaphragm are the shortest. The sternal fibers of origin of the diaphragm are the shortest, and those origins from the ninth rib and the costal cartilage. Ninth rib and the costal cartilage are the longest. So the sternal fibers are the shortest, and the ninth costal origin, that is the fibers originating from the ninth rib along with their costal cartilages are the longest. So this is about the origin of the diaphragm. So as you can understand here, the peripheral part of the diaphragm is muscular. Now what about the insertion of the diaphragm? The diaphragm is inserted, all these fibers will be inserted into a central tendon of the diaphragm. You can see here, this is the central tendon of the diaphragm. Which is not muscular but fibrous in nature. And the central tendon looks like a trifoliate leaf. Now when you are seeing the diaphragm from the abdominal side, so this is the inferior surface which you are seeing, this is the right side, this is the left side. So the central tendon of the diaphragm is shaped like a trifoliate leaf, and it has got a median leaflet or a central leaflet, a left part and a right part. It is shaped like a trifoliate leaf, and it is not muscular but it is fibrous, and the central tendon owes its developmental origin. It is developed from a primitive structure which is known as septum transversum. And the septum transversum also gives rise to the fibrous pericardium of the heart. This septum transversum also gives origin to the fibrous pericardium of the heart. This is the reason that the central tendon is, I will show you in the specimen, that central tendon of the diaphragm is inseparably blended, it cannot be separated, inseparably blended with the fibrous pericardium of the heart. And from all the sides, the convexities of the diaphragm peripherally, they will be converging into the central tendon of the diaphragm, which will sit over the liver, at a concave area. So on both sides the diaphragm is convex, and in the central part it is concave, which is occupied mainly by the central tendon. So this is all about the origin and the insertions of the diaphragm. Now the other parts I will discuss now, that is the openings of the diaphragm. Now the openings of the diaphragm, what are the significance of the openings? I have already told you that the thoracic outlet is closed, and the structures from the thorax needs to get certain openings through which they can enter into the abdomen. So these openings are certain areas within the diaphragm through which the structures will pass. Now the openings of the diaphragm, they are very important for your examination. The openings of the diaphragm are mainly of two types: the major openings as well as the minor openings. The The major openings are mainly 3. Major openings are 3 in number. What are they? Number 1, the vena cava opening. The vena cava opening. Where is it situated? The vena cava opening is situated at the level of the intervertebral disc between T8 and T9 vertebra. The vena cava opening is situated at the level of the intervertebral disc between T8 and T9 vertebra, and it is situated in the central tendon of the diaphragm. You can see here, this is the central tendon and this is the vena cava opening. It is situated in the central tendon of the diaphragm, close to the intersection of the central and the right leaflet. I have already told you earlier that the central tendon is shaped like a trifoliate leaf. So it has got a central or the median part, a left part and a right part. So the esophageal, the vena cava opening of the diaphragm is situated at the level of the intervertebral disc between T8 and T9 in the central tendon of the diaphragm at the point of intersection of its median leaflet and the right leaflet and it is situated about 2.5 centimeters to the left of the median plane or the midline, 2.5 centimeters to the right of the median plane or the midline. So this is about the topographical situation of the vena cava opening. Now what about the shape of the vena cava opening? It is almost quadrilateral in shape. It is almost quadrilateral in shape. Now the structures passing through the vena cava opening. Structures passing through the vena cava opening. The structures passing through the vena cava opening, as the name suggests, is the inferior vena cava. So the inferior vena cava will pass through the vena cava opening. The other structures passing through the vena cava opening are the right phrenic nerve. The right phrenic nerve also passes through the vena cava opening. And the third structure, which is not that important, the third structure passing through the vena cava opening are a few lymphatics from the liver. Now the outside coat of the vena cava opening is fused with the central tendon of the diaphragm. So what is the effect of inspiration in the vena cava opening? What is the effect of inspiration to the vena cava opening? So during inspiration, as the central tendon is fixed to the outer coat of the inferior vena cava, as the diaphragm contracts, the opening of the inferior vena cava dilates so that more blood will reach the right atrium. So this is the effect of inspiration to the vena cava opening. So the vena cava opening will dilate so that more blood will reach the right atrium. So this is about the vena cava opening. Now the second opening, that is the esophageal opening. Now I have already told you that the esophageal opening is formed by splitting of a few fibers of the right crus. You can see here the right crus, the more fleshier. So it is formed by splitting of a few fibers of the right crus. The esophageal opening is situated in the muscular part of the diaphragm at the level of the 10th thoracic vertebra. So it is situated in the muscular part of the diaphragm at the level of the 10th thoracic vertebra and formed by splitting of a few fibers of the right crus, and it is unlike the vena cava opening. The esophageal opening is situated 1.25 centimeter to the left side of the midline. The vena cava opening was situated 2.5 centimeter to the right side of the midline in the central tendon, but the esophageal opening is situated 1.25 centimeter to the left side of the midline in the muscular part of the diaphragm, Now, what are the structures passing through the esophageal opening? As the name will suggest, the esophageal opening will transmit the esophagus. So, number 1, esophagus. Number 2, the anterior and the posterior vagal trunks. Now, you know in the thorax there are 2 vagus nerves, the right vagus nerve and the left vagus nerve. Now, going to the lower part of the thorax, the vagus nerves are known as, or they will form the anterior and posterior vagal trunks. Now, the anterior vagal trunk is formed by the left vagus nerve, whereas the posterior vagal trunk is formed by the right vagus nerve. So, the structures passing through the esophageal opening are the esophagus, the anterior and the posterior vagal trunks, a few lymphatics from the liver. 3. Number 4, esophageal branches of the left gastric artery along with the tributaries of the left gastric vein. So, esophageal branches of the left gastric artery along with the corresponding tributaries of the left gastric vein. Now, the other structures, so 4. And number 5, fifth structure passing through the esophageal opening is the phrenoesophageal ligament. So, these are the structures passing through the esophageal opening. Now, what about the shape of the esophageal opening? It is elliptical in shape, just like an ellipse, elliptical in shape. And what about the effect on contraction of the diaphragm to this esophageal opening? Now, as the fibers of the right crus split to form this esophageal opening, so upon contraction of the diaphragm, what happens? The esophageal opening will close or constrict. So, during inspiration, when the diaphragm contracts, the esophageal opening constricts. That is why respiration or inspiration and deglutition cannot take place at the same time, because when we are taking inspiration, we are inspiring air. The esophageal opening, due to the contraction of the right crus of the diaphragm along with its fibers which split to form the esophageal opening, will also contract, and the esophageal opening will constrict, and that is why it will prevent the entry of food into the stomach. This is the reason why inspiration and deglutition cannot take place at the same time. So, this is about the second major opening, that is the esophageal opening. Now, the third major opening is the aortic opening of the diaphragm. Now, the aortic opening of the diaphragm is actually a osteoaponeurotic opening. Now, the vertebral level of the aortic opening of the diaphragm, perhaps you know, it is the lower border of the 12th thoracic vertebra. Lower border of the 12th thoracic vertebra. So, the boundaries, and it is situated slightly to the left of the median plane or the midline. Slightly to the left of the median plane or the midline. So, what are the boundaries of the aortic opening of the diaphragm? Posteriorly, there is the body of the 12th thoracic vertebra. Posteriorly, there is the body of the 12th thoracic vertebra. Anteriorly, it is bounded by the median arcuate ligament. Median arcuate ligament, which connects the right and the left crura of the diaphragm. Right and the left crus of the diaphragm. And on both sides, there will be the right crus and the left crus of the diaphragm. So, these are the boundaries of the aortic opening of the diaphragm, situated at the level of the lower border of 12th thoracic vertebra, slightly to the left side of the midline. Now, what about the shape of this opening? It is almost rounded in shape. It is almost rounded in shape. And what about the effect of contraction of the diaphragm to this opening? There is no effect. There is no effect. There is no effect. That is, it will neither constrict nor dilate when the diaphragm will contract. When the diaphragm will contract. And by knowing the boundaries of this opening, you perhaps now you have understood that why it is known as a osseo-aponeurotic opening, because posteriorly it is osseous, it is formed by the body of the 12th thoracic vertebra, and anteriorly and on the sides, anteriorly it is formed, the boundary is formed by the median arcuate ligament, and on both sides by the crus of the diaphragm. That is why this opening is osseo-aponeurotic. Now, what will be the structures passing through what are the structures passing through the aortic opening of the diaphragm? The structures, as the name suggests, name of the opening suggests, it is the descending thoracic aorta. The descending thoracic aorta, as soon as it passes through the aortic opening of the diaphragm and enters the abdomen, will be known as the abdominal aorta. So, descending thoracic aorta, number 1. Number 2, a very important structure, that is the thoracic duct. Thoracic duct. Thoracic duct. And number 3, this may pass or may not pass, that is the azygous vein when it arises as the lumbar azygous vein. So, as a number 3rd structure is the azygous vein when it arises as the lumbar azygous vein. So, these are the 3 structures which passes through the aortic opening of the diaphragm. Effect upon contraction, there is no effect on the opening. It will neither constrict nor dilate. No effect. So, these are all about the major openings of the diaphragm. Now, I will go there are many minor openings of the diaphragm. I will tell you about 3 or 4 minor openings, and some structures will pass also through the minor openings. So, what are the minor openings? Number 1, the space of Larry. Space of Larry. What is space of Larry? It is a space between, you can see here, between the sternal or the xiphisternal origin of the diaphragm and the 7th costal origin of the diaphragm. I am talking about this space on both sides. Perhaps you can understand this space on both sides, the sternal origin and the 7th costal origin of the diaphragm. There is a space which is known as space of Larry. The structure passing through the space of Larry will be the superior epigastric vessels. Superior epigastric vessels. So, this is one of the minor openings of the diaphragm. Another minor opening of the diaphragm is between the 7th and 8th costal origin of the diaphragm. 7th and 8th costal origin of the diaphragm, through which the musculophrenic vessels will pass. The second minor opening is between the 7th and 8th costal origins of the diaphragm, through which the musculophrenic vessels will pass. The third opening, these are between the interdigitations. I already told you that the costal origins of the diaphragm are from the lower 6 ribs along with their costal cartilages, and these origins interdigitate with the origin of the transversus abdominis muscle of the anterior abdominal wall. So between these interdigitations of the origins of the diaphragm from the lower 6 ribs and the origins of the transversus abdominis, the lower 5 pairs of intercostal vessels and nerves will pass. So between the interdigitations of the costal origins, lower 6 costal origins of the diaphragm and the origin of the transversus abdominis, the lower 5 intercostal vessels and nerves will pass. So this is about the third minor opening of the diaphragm. Fourth one, that is below the medial arcuate ligament. Medial arcuate ligament. There is also a small opening below the medial arcuate ligament, the right and the left. The structure passing below the medial arcuate ligament or beneath the medial arcuate ligament on both sides, you can see here this chain-like structure. It will be the sympathetic chain or the sympathetic trunk. This is about the fourth minor opening. Now the fifth minor opening. Fifth minor opening will be below the lateral arcuate ligaments, the right and the left. The lateral arcuate ligament. The structures passing below the lateral arcuate ligaments on the both sides will be the subcostal vessels and nerves. You can see here vein, artery and nerve, vein. Subcostal vessels and nerves. So the structures passing below the lateral arcuate ligament will be the subcostal vessels and nerves. This is about the fifth minor opening. Now there are also certain structures that will pierce the crus of the diaphragm. The crus of the diaphragm are pierced by the greater and lesser splanchnic nerves, both the crusses, because the splanchnic nerves will arise from the sympathetic ganglion. When the sympathetic ganglion will be taught to you, you will know about the greater and lesser splanchnic nerves. I am not going into the details of it, but the greater and lesser splanchnic nerves will pierce the right and the left crus of the diaphragm. And also the left crus of the diaphragm as a rule is pierced by the accessory hemiazygous vein. Accessory hemiazygous vein on the left side. We have already been taught about the azygous system of veins. You know what is accessory hemiazygous vein. So the left crus as a routine is pierced by the accessory hemiazygous vein. So these are all about the minor openings of the diaphragm. Minor openings of the diaphragm. Now what about the nerve supply of the diaphragm? The motor supply of the diaphragm. The motor supply of the diaphragm comes mainly from the pair of phrenic nerves, which owes their origin from the cervical plexus. Root value is C3, C4 and C5. That is from the cervical plexus, C3, C4 and C5. So the motor supply of the diaphragm comes from the right and the left phrenic nerves. Now here is a very important thing that will be asked in the examination. Both the phrenic nerves will not supply the diaphragm from its superior surface. Rather, they will go below the diaphragm and will divide into 4 branches. into 4 branches to supply the diaphragm from its inferior surface. So how will the right and the left phrenic nerve go below the diaphragm and supply it from its inferior surface? The right phrenic nerve, I have already told you, it will go through the vena cava opening as a rule. So the right phrenic nerve goes through the vena cava opening, whereas the left phrenic nerve will pierce the left cupola of the diaphragm, slightly anterior to the central tendon. So the left one will pierce the diaphragm, the left cupola of the diaphragm, or the convexity of the diaphragm, slightly in front of the central tendon. Thus, these 2 nerves will go below the diaphragm and will divide into 4 branches and supply the diaphragm from its under surface. This is about the motor supply. What about the sensory supply of the diaphragm? The central part, the sensory supply comes from the phrenic nerve. So the sensory supply to the central part of the diaphragm comes from the phrenic nerve, whereas the peripheral part, the sensory supply is provided by the lower 5 intercostal nerves. So central part sensory supply comes from the phrenic nerve, whereas the peripheral part is supplied by the lower 5 intercostal nerves. This is about the sensory supply. And the sympathetic supply comes from the celiac plexus, which is not that important. Now, what about the arterial supply of the diaphragm? The arterial supply comes from the following arteries. Number 1, the musculophrenic artery. Number 2, pericardiophenic arteries. Number 3, superior phrenic artery, which is the last branch of the descending thoracic aorta. Superior phrenic artery, which is the last branch of the descending thoracic aorta. And last but not the least, the inferior phrenic artery, which is the first branch of the abdominal aorta. Inferior phrenic artery, which is the first branch of the abdominal aorta. This is about the arterial supply of the diaphragm. Now, if you think about the development of the diaphragm, comes from various sources, but the most important thing that you need to know that the central part of the central tendon of the diaphragm is developed from the primitive structure which is known as the septum transversum, which also gives origin to the fibrous pericardium of the heart. That is why the central tendon is inseparably blended with the fibrous pericardium of the heart. The peripheral part is partly formed by a shelf-like projection from the developing body wall, shelf-like projection from the developing body wall, and also a part of the diaphragm is developed from the closure of the pleuroperitoneal openings. So this is all about the development of the diaphragm. The last but not the least, the applied part. The applied part, you already know what is foramen of Morgani. When the diaphragm fails to take its origin from the xiphoesternum. When the diaphragm fails to take its origin from the xiphoesternum, there may be a retrosternal opening here. So these openings will not be present. So these not openings, these fleshy fibers from the xiphy sternum will not be present. So there will be opening there, which is known as sinus of Morgani, through which the abdominal contents may herniate into the thorax, which is known as Morganian hernia. Another thing is the costovertebral trigone. When the diaphragm fails to take its origin from the lateral arcuate ligament, there may be a opening here through which the abdominal contents may herniate into the thorax. This is what is known as costovertebral trigone, or this foramen when formed is known as foramen of Bogdalek. So these are about the two types of the diaphragmatic hernias. So in short, this is all about the theory part of the diaphragm. The next part I will just demonstrate the specimen of the diaphragm. Now here you can see this is the specimen of the diaphragm. How will you find out that which one is the superior aspect and which is the inferior aspect? The superior aspect will contain the attachment of the fibrous pericardium. You can see this is the fibrous pericardium. So this is the superior aspect of the specimen. And the anterior and the posterior, how will you determine that which one is the anterior aspect of the specimen and which one is the posterior aspect of the specimen? Now one thing, the attachment of the fibrous pericardium will be more close to the anterior margin of the specimen. This is the anterior margin of the specimen. You can see this is the anterior margin of the specimen. The attachment of the fibrous pericardium will be close to the anterior margin of the specimen when compared to its posterior margin. You can see here this is the posterior margin of the specimen. So here is the fibrous pericardium. You can see the distance. The distance of the fibrous pericardium from the posterior margin is much more greater. The distance here from the anterior margin of the specimen is lesser. So this is the superior aspect of the specimen and this is the anterior aspect. And to help you here, this specimen also contains the aorta, the descending thoracic aorta, which will lie obviously the posteriorly. And you can see here the right crus. This is the right crus. The left crus cannot be seen here very prominently, but the right crus is more bulkier, and you can see here the right crus. And how to hold the specimen in anatomical position? You just hold it like this. The right cupola, the highest point, will be at a higher level when compared to the left cupola, because of the more massive right lobe of the liver. So you hold the diaphragm in the anatomical position like this, and the central tendon, if you hold it against the light, you can see the central tendon, which is like a trifoliate leaf. You can see here the right leaflet, the left leaflet will be here, and the central leaflet or the median leaflet will be here. And last but not the least, the openings. Anterior in the muscular part of the diaphragm, just anterior to the central tendon will be the esophageal opening. You can see here, this is the esophageal opening. It will be in the muscular part of the diaphragm, not in the central tendon. And in the central tendon of the diaphragm, at the junction of the right and the median leaflet, this opening is the vena cava opening of the diaphragm. And the aortic opening of the diaphragm is actually musculo-aponeurotic. It will be, you can perfectly see the descending thoracic aorta here. So the aortic opening cannot be shown here because it is a musculo-aponeurotic opening. And you can see both the phrenic nerves here. The left one goes by piercing the left cupula and the right one goes through the vena cava opening. So this is all about the diaphragm. Thank you.